Good afternoon, ladies and gentlemen. It is my honour and a privilege to speak to you today at the launch of this really exciting collaboration. My name is Dr. Colin Gorman. I'm a clinical psychologist and a member of the academic team at Ulster University here in Northern Ireland. I'm going to give you a short presentation to overview some of the approaches that we take to understanding and treating trauma, particularly post-traumatic stress disorder and complex post-traumatic stress disorder. First of all, I'd like to say we're extremely grateful to be offered this opportunity to collaborate with Kyiv Medical University, and we're really looking forward to the range of work that we will be doing together in the future. So the brief talk that I'm going to give today relates to aspects of the work that we're doing with trauma. This will focus on a number of things. It will focus on a broad clinical framework that we will use in order to understand clinical presentations. But then it'll go a little bit further and more detail into the trauma, how we approach trauma, the differences between PTSD and complex PTSD, and then the importance of research and informing practice. And finally, I will briefly talk about some of the practicalities in working with people who have been traumatized. Okay. This is a reasonably short presentation, a short lecture, but unfortunately, some of the issues that we'll be discussing do relate to the most horrific events that we have experienced in Northern Ireland. And unfortunately, the situation in the Ukraine at present means that these issues are all too real on a daily basis for many of you. And thus, I would start by saying, as I would always start such a lecture with my own students, it's imperative to take care of yourself. If the details or the content feels overwhelming or too personal, it's always okay to exclude yourself. It's always okay to keep yourself safe, to leave or to seek help. We're aware that this is your daily reality and it has been for too long, that no one is completely safe and that threats are ongoing. And we would encourage your practitioners to think about some of the potential impact of talking about trauma and working with trauma if you're living and working in an unsafe environment. We all need to look after our own mental health, whether we're psychologists, academics, or members of the general public. So I will give you some context to the situation in Northern Ireland, and then I will talk about a generic clinical framework. I will then introduce trauma and complex trauma and some of the research that we've been doing at Ulster University. And then finally, what I'll say is something about the challenges of engaging individuals in clinical work to treat trauma, PTSD, and complex PTSD. So before I say a little bit about trauma, I think it's important to give you some background on our country, the history of our country, and the civil unrest which we have experienced over a number of decades. Thankfully, our situation has improved drastically, although unfortunately, our troubles have not completely disappeared. To give some background to the Northern Ireland Troubles, as you'll see in the map here in the right-hand corner, Northern Ireland is, as the name would suggest, in the north of the island of Ireland. This part of Northern Ireland is governed from London, as is Scotland, Wales, and England, which make up what is called the United Kingdom. The politics are complex, but to oversimplify, half of the population of this part of the island feel a closer affinity to Dublin and the Republic of Ireland, while half feel more connected to the United Kingdom. These politics have led to decades of civil unrest, which we in Northern Ireland have called the Troubles, in which over 3,500 people have lost their lives. Many more have been physically injured. And as I will discuss, multiple generations will continue to live with the psychological impact. These complex demographics led to conflict within this country and started nearly in the early 1960s and did not come to an end until around 2005. So we experienced around 40 years of conflict within our country. Sometimes it's very difficult to pinpoint where these complex circumstances originated, but people will point back to the civil rights movement of the 1960s, between 1964 and 1972, as being a bit of a catalyst for a number of events which have led to the atrocities within the Troubles. Some of the other more significant events over the last 40 years include the Bloody Sunday events that took place in Derry within Northern Ireland. And this Bloody Sunday has been made quite famous by the song by the Irish rock band U2. There was also what was called the hunger strikes that were carried out by prisoners in 1981, which was a significant milestone in the conflict. And during this time, 10 prisoners starved themselves to death. In 1998, an agreement was, however, made by those involved in the conflict, and this set the scene for 2005, when the Irish Republican Army, who were one of the main paramilitary organisations operating in Northern Ireland, called a ceasefire. As you can see from the photographs on the right-hand side, our own university, which is in the top left, has actually been directly affected by these troubles. In particular, during the early stages of the conflict, a bomb was left in a lecture theatre in our Georgetown campus, while another incident in our London Derry campus resulted in the murder of 3 people. One person was shot dead, and 2 further members of the police force were killed when a bomb exploded on this McGee campus, which you see here, as I said, on the top left-hand corner. Thankfully, we have come a long, long way since these dark days. But one of the very important lessons learned is that while great attempts are made to ensure that normal life goes on, no institution or individual is immune from the effect of war situations. We therefore need to acknowledge this for our staff, for our students, who are trying to live normal lives while the circumstances around them are far from normal. The distinction between lecturer and student, therapist and client is much less clear in this situation. Trauma can metaphorically and literally be in the classroom and in many, many levels. So what have been the consequences of 4 decades of civil unrest? Well, research shows that in Northern Ireland, we have twice the rate of post-traumatic stress disorder symptoms as our neighbouring counties in the Republic of Ireland. As I mentioned earlier, Northern Ireland on this map is the dark orange area in the north of the island. What that says is a person who lives 1 mile inside that line is twice as likely to have PTSD as a person living 1 mile the other side of that line. So there's a big difference living inside the borders of Northern Ireland. A second issue is the psychological consequences are not just felt by those with direct experiences of the conflict. It's also found in this research, in the same survey conducted by Ulster University, that 54% of the population indirectly experienced a related traumatic event. This is extremely important as we see a ripple effect of conflict and how you don't have to be a direct victim to be affected by it. So in real terms, it was found that Northern Ireland has approximately 5.1% rate of PTSD in the population. So this translates to 1 in every 20 people meeting the criteria for post-traumatic stress disorder. When this study was completed a number of years ago, this was one of the highest prevalence rates internationally. And an additional significant issue in this context, one which has major implications and which we're only fully understanding and appreciating in more recent times, is the evidence of what we know as transgenerational trauma. This builds upon the idea that it's not only those who have had direct experience, as I said, of the conflict, or have directly witnessed the horrific events who it will be impacted upon, but also their families, their friends, and their communities. Very importantly, it's been shown in Northern Ireland that even children born after the ceasefires, they are continuing to be impacted upon by the situation and the circumstances that their parents faced. So in a survey of the impact of the Troubles, which was completed almost 12 years after the war had ended, it was found that post-traumatic stress disorder was not only the only psychopathology that emerged as a consequence of the civil unrest, Although over a third of those with a pathology did have post-traumatic stress disorder, a quarter of people in the survey would have a depressive disorder following the troubles, and 5% had other anxiety disorders. Around a third of those who have had some form of psychopathology would have a combination of PTSD, mood disorders, and other types of anxiety disorders simultaneously. Drug and alcohol use and abuse is also a major concern for many. So the psychological picture is therefore very complex. More recent research has emphasized this point, that the end of the conflict does not always necessarily bring about the end of the challenges and the psychological difficulties that the community and the society will endure. A recent youth wellbeing prevalence survey conducted in Northern Ireland by our colleagues at Ulster University in collaboration with other partners found 1.5% of young people in Northern Ireland have post-traumatic stress disorder, and 3.4% have complex post-traumatic stress disorder. The distinction between these I'll talk about a little bit later, but it was found that 1 in 4 people said that the troubles had impacted upon their family, and this is within the last 5 years. On top of this, 23% of young people and 43% of adults said that the paramilitaries in Northern Ireland continue to create fear and intimidation. This is almost 25 years after the Belfast Agreement was signed. So again, despite the hope that many of us have had, and there's undoubtedly definite improvements in the safety and the broader landscape of Northern Ireland, unfortunately, there are still paramilitary activities that are active within our communities and are still creating terror and perpetrating atrocities which impact upon families within Northern Ireland. So this story about the long-term legacy of conflict, unfortunately, it's more than just the direct impact of violence. When the bullets and bombs have stopped, this was not the end of the psychological impact. And in many ways, this was the beginning of the process of healing and recovery. I think this is important for the Ukraine regarding what can be achieved when there still is threat, there still is uncertainty, and that real threat does continue to remain. But despite actually this civil unrest and conflict that I've talked about and that we've experienced over many decades, we do know also that challenging times do not have to always lead for everybody to have devastating consequences. It can at times have some unexpected positive impacts, particularly in uniting people and communities, creating a sense of pride and belonging, sense of identity, and even for those who have suffered greatly, post-traumatic growth is not unusual. This is the case where surviving major traumas can result in a greater appreciation of life, of loved ones, and some of the more simple pleasures and luxuries and freedoms that have been important to us. So turning to clinical practice, I thought it'd be useful to talk about two aspects of our clinical practice. The first is to explain a very overarching framework that guides the work that we do. The top section here is the sources of information that we use in order to inform our clinical activity and the processes that we engage in. This is what we draw on to guide all our clinical activity, and particularly focusing on our clinical interventions, and particularly around the assessment phase. So the first phase, as you'll see where the arrow is pointing here to the green circle, will always involve a very comprehensive biological, psychological, and social assessment of a clinical presentation. This biopsychosocial assessment, as we call it, of the presentation, then leads on to the identification of whether this individual is appropriate for a specific type of therapy or intervention. A formulation will be made of the patient or the client's difficulties, which can include a provisional diagnosis based on an established diagnostic framework. This formulation will potentially be informed by a range of psychological, social, and biological models. It's therefore important for us that this formulation then guides the treatment intervention that is offered to the client. That is, building the theoretical model that has helped us understand the treatment focus and the expected outcomes. And following on from this intervention stage, there's always a process of review where we have objectively evaluated the efficacy of the intervention. And this cycle will continue. Should the intervention be effective, then it's a very positive outcome. However, if there's not full recovery or the treatment has not been successful, what we will do is we will engage in a process of reassessment, reformulation, what the difficulty is, and therefore leading to different treatment targets and using a different theoretical model. So then the cycle will continue to gain, working through each of these stages systematically. This is likely to be very familiar to any of the clinicians in the audience who will have a similar structure that informs the movement between gathering comprehensive information, then making some sense of the information, implementing a treatment program, and then having a robust process for reviewing whether that outcome has been successful. So, as I said, this clinical activity will be based on psychological knowledge. The first area of the psychological knowledge is the theoretical model from which we're drawing on. The theoretical model can be a singular model, or it can be an integration of a number of models. Frequently, interventions draw on biological interventions, such as medication, but also other models like cognitive models, behavioral models, psychodynamic models can be used. Many theoretical models are available. However, they're not all equal in terms of demonstrating effectiveness, and this is really important. So the theory will have a large part to play in informing the type of formulation that an individual will arrive at. But the second important dimension is about the centrality of research in driving the choices that we make about what is going to work. And also the importance of research in evaluating then the effectiveness of the specific types of intervention. So we can innovate, we can consistently improve what we're doing and understanding particular presentations. So it's drawing on the best quality evidence and the best quality research to help us to complete a top class assessment process. But also this research will help us to understand the strengths and weaknesses of particular theoretical models and whether they're actually working in practice. Then the research will ultimately be about testing. Has the intervention done what we hoped it would do? Usually in terms of reducing specific clinical symptoms that are the target of our treatment. So routine evaluation of all treatments is a very central aspect of what we do. This is part of our training, but also informs the monitoring of outcomes when psychologists are qualified and working within the National Health Service. But the third aspect of this funnel process is for the clinician to not forget about the challenges and opportunities of our own clinical and our own personal experiences. It's about the clinician being able to draw on their own history, their own life story, but also in drawing on their own knowledge and experiences of your current life circumstances in which you live. This will help the practitioner to understand the challenges that the individual patient or client is presenting with. When they come from health from a clinical psychologist, and hopefully this will inform realistic expectations for improvement. So I think this is really, really important on a number of levels. So on one level, the clinician's experience of safety within their own world, as well as security within their professional boundaries and their professional role in the teaching and training and working with clients. Of course, clinical supervision will support the clinician in trying to keep themselves safe in order to allow the clinician to offer the best service to the client. So these dimensions that are presented are really, really important in finding the correct balance between them so that we can have the most effective and most efficient treatments for getting successful recovery for any individual that draws on theoretical models, draws on the clinician's personal experience, but also has research as central to that process in understanding what has shown effectiveness in working. So I've highlighted the importance of the assessment process and how important it is to get the correct information and understanding, which will lead to your formulation and appropriate treatment. But I now want to talk very briefly about some of the work my colleagues at Ulster University, Professor Mark Shevlin and Dr. Enya Redican have been doing in separating out the difference between different trauma presentations. So PTSD and what's being called complex PTSD or CPTSD. Professor Shevlin and Dr. Redican have published some very influential work that has meant that the distinction between post-traumatic stress disorder and complex PTSD have been entered into the ICD-11 as separate categories. And this is very important in terms of our understanding these categories, but also will have specific implications for how we not only research, but we treat these conditions. Through the work of Professor Shevlin and his colleagues, they have established clear evidence that PTSD and complex PTSD are distinct presentations. Here's a brief summary of their findings, and I'll show some papers in a while that you can find this more information on this. But this demonstrates overlaps between PTSD on your left-hand side and complex PTSD on the right. And these are in areas of re-experiencing the trauma, avoidance of the trauma, a perception of ongoing threat, and as well that there will be an aspect of functional impairment in the patient's presentation. But what you'll see on the right-hand side, that a distinct presentation of complex PTSD is different and has additional characteristics which cluster together to make it a separate entity and worthy of a different classification within ICD-11. These more unique features not occurring in classical PTSD are affect regulation, emotional regulation, negative self-concept, and also relationship difficulties. I use this example to show how high-quality research has been instrumental in helping us to understand how to conceptualize and categorize trauma. But additionally, this research, it also informs the assessment process and potential treatment paths that a person who experiences traumatic experiences will have to go through. So I've given two papers by Professor Shevlin and Dr. Redican and their colleagues that highlight some of the implications of these findings and how that altered the diagnostic criteria within the ICD-11. So that's the second paper on the latent structure now of the post-traumatic stress disorder and complex PTSD. So I'll highlight just one of the major implications. There's a number of implications for clinical practice, but I'll highlight one, which is the distinction just between PTSD and complex PTSD. This is needed to identify. You need to identify this in the assessment process in order to guide the treatment pathway. Professor Shevlin and his colleagues have established what is known as the ITQ, the International Trauma Questionnaire. And this is shown to be a very valid tool for making this decision that will help the clinician in their treatment planning. And I'm very pleased to say that Professor Shevlin and his colleagues through the International Trauma Consortium have made these measures available in Ukrainian and have supplied additional resources to support those affected by war. And the link to the website is at the bottom of this slide. And in addition to that, as part of this International Trauma Consortium, there continues to be ongoing research through this consortium that is studying the mental health and well-being of parents and children in the Ukraine at this moment in time. And again, this is the type of research that we hope to build on as we evolve this unique opportunity to develop professional and therapeutic skills that will have a direct impact on the lives of those that have been affected by the war in the Ukraine. So moving briefly on to discuss the current research on the treatment of trauma, there have been many reviews that have been carried out in this literature, and there's established evidence based that cognitive processing therapy and EMDR have been shown to be effective in treating PTSD. Other treatments which involve a therapeutic ingredient of some sort of prolonged exposure has also been shown to be effective. And many other treatments have been tried with PTSD with mixed results, and there is more quality evidence that are needed to establish their value. But I want to talk a little bit about sort of the challenges, as some people might expect that, a manualized approach to treating trauma might be possible. But I want to talk about the challenges of treating trauma in clinical practice and in the real world. As PTSD is categorized as an anxiety disorder, and a core maintaining factor for any anxiety disorders is avoidance. Very often what is needed to treat trauma is the last thing that a person wants to do. So this is where the skills of the clinician are really, really essential in helping the patient to complete a successful treatment. This seminal work on trauma by Judith Herman has identified 3 stages in the treatment of trauma that fits nicely with a lot of those models. Firstly, it's necessary to establish a safe and secure environment for the patient where they feel safe. If this is not the case, the patient will often not be able to move to stage 2. This first stage might take a lot of time on the part of the therapist, building safety, building security, and building trust. And how long does it take to build trust in someone? It can take a little bit of time, but it is necessary to get this through this first stage in order to move to the second stage that Herman identifies. So stage 2 is the active part, where there's usually exposure to the memories to assist in the processing of the trauma. This can be a very challenging phase and will include the person's appraisals about their role in the traumatic experiences and things they did do and could have done and might have done and should have done. And very often people will take responsibility for some of the tragedies that they have been involved in. And the third phase is really important following this processing phase, is usually around helping the patient to reconnect with those around them, returning, as many will have left, meaningful activities. So returning to this meaningful activities, such as work and hobbies, and becoming part of a community again. As I said, as many people with trauma will isolate and will withdraw from people and withdraw from their society. So I think this is a very useful framework for thinking about the stages of trauma that complement some of the other theoretical models that we use. So there are many challenges in telling the story, and the challenges in starting to tell the story, which is necessary in treatment. And these things tend to include shame, humiliation, fear, vulnerability, depression. And for a clinician just to have techniques in order to facilitate a person to start telling this story is essentially important. So there's many factors that can impact on this storytelling process. These are things like just getting the right person at the right time, having trust that the therapist is able to handle the awfulness of some of the stories and the details. Some people will worry about that their own experience does not compare to the trauma of others. It's not as bad as what other people have been through or experienced. And also some methods of telling stories are not suited to some people. So wanting to use creative mediums to tell their story instead of verbally communicating, putting words and language and speaking the story out. And finally, some people feel so overwhelmed that they just don't know where to start in telling the story. The story has the memories of the story are so interlinked, and it doesn't, for many people, have a natural start, middle, and an end. Knowing where you might start telling the story, again, is an important aspect of this process. Other sort of challenges in telling the story, sort of moving past some of those more fundamental and primary ones, are just about how the impact of trauma can lead to shame, personal shame, and mistrust of others because of interpersonal trauma and the impact that can have on people. So the shame and mistrust, there may be concern about the personal consequences on self of disclosing acts which have been committed against you, or some of the acts that a person has done. There's also concerns, there can be issues of dissociation, memory loss that are core to trauma. And also we have to take into consideration aspects of the trauma that are still ongoing, that mean that they're unable to get past that trust phase of stage 1. But there are general strategies in which we can use in therapy to help the individual feel control and begin to engage in the story and the memories of the lived trauma. So most importantly, these include going at the client's pace, taking your time, showing flexibility and giving control and responsibility to the client. Use of creative means can be very, very useful. Things like timelines, getting them to write out their timeline of events, using maps of the locations maybe in which things happened, or genograms, looking at family relationships and family dynamics and how they may be influential in part of the story that an individual needs to tell. These can be a safer vehicle for beginning to tell the story. So use of publicly available media sources can sometimes help a person to remember the events and what was happening at that time, and they contextualize the story, making beginning to tell it easier and maybe giving them a starting point. But also using music, art, poetry, other creative medium can be a really great way to facilitate self-expression in a way that initially engages the traumatized individual to, for some it's getting active too, to physically move, but also then start to express their feelings and emotions and the memories in another form. So, you know, that was a whirlwind overview of some of the things that I think are important in the understanding, the research and treatment of trauma. So I'm just going to finish by returning to the Judith Herman phases that I talked about, the 3 stages of PTSD treatment, and I want to send wishes to the country and the people of the Ukraine that soon you do find a place of peace, a place of safety, a place of stability, that you're able to begin to understand the psychological impact of the last 3 years, and that can be consigned to history. It can be something that is in the past and that is not still part of the present, that it's a memory rather than being part of daily life. And from the 3rd phase, that the people of Ukraine remain together, remain strong and connected and supportive of each other through these very difficult times. So I just want to say a very thank you very much. Dayaku Sim. Hopefully I've said that right. Thank you, and I look forward to working with you all in the future. Thank you now. Take care.